me introduce Eve. I probably don't need to introduce her, but she's our moderator for today. Dr. Eve, she's the programs manager at APCA.
Hi, Eve.
Eve, are you speaking? We are not hearing you. IT, maybe you can help us to get Eve with Eve's audio. Your audio, we are not getting you, Eve. Dr. Watiti, it's good to see you. It's been a while.
Nice to see you. It's been a while, yes. Nice seeing you.
Yeah. Eve, we still cannot hear you, so maybe between you and Frank, you can try and sort out your audio before Frank opens it actually to everyone. Okay, sorry, we'll just give it another couple of minutes for Eve to sort out her audio. Thank you all for coming in. We've received a couple of questions actually that have come ahead of the session. So maybe I can post them in the Q&A and you might want to already reflect on them because they are questions for the panelists. So even if you can start to address them in your presentation, that would also be good.
With Zerai, can you hear me now?
Eve,
yes, we can hear you now, Eve. That's great. Okay, so Eve, I was just saying that there are some questions that we received earlier before the session even started. So I'm going to put them in the Q&A so the panelists can already see them in case they are able to address them already in their presentations.
Okay.
Okay. Thanks. So I think Frank, it's okay now. You can open the session to everyone.
We're broadcasting. You can go ahead and start.
So you're all very welcome to this seminar. You're all very welcome to this seminar, and good afternoon, good evening, or good morning, wherever you may be. So we are going to be talking about access to controlled essential medicines in Africa, state of affairs. And I'm pleased to introduce the panelists on this seminar. We are going to have Dr. Catherine Kanari. We are going to have Mr. Adelo Adebayi. We are going to have Ms. Edith Andrews, Anna. And we are going to have Dr. Stephen Watiti, and then Anna Dolocent, who is also a patient.
Et notre bénéficiaire est patient.
And we will also have some reflections
On aura aussi
Dr.
quelques
Catherine
réflexions du docteur Catherine Pettas.
So our first speaker is going to be
Donc,
Dr. Catherine Kanari.
Première
And she's going to talk to us about
Présentateur sera
integration
le
of
docteur Catherine
access to
Canary. Donc, on
controlled
va
medicine
parler
in
de
programs across
l'accès
Africa.
aux
Dr. Catherine
médicaments contrôlés
Canary
en
holds a
Afrique.
Bachelor of Medicine and Surgery
Donc,
degree from the University of
est
Nairobi,
titulaire d'un
and
diplôme
she holds a
en médecine de
Master's
l'Université de
of Public
Nairobi
Health
et un
from the
master
International
en santé
University
publique
of
de
Leeds, United
l'Université
Kingdom.
internationale de
She has
Leeds
more than
au
14 years of
Royaume-Uni.
experience
Elle a
in the
plus de
health
14
sector
années
in Kenya,
d'expérience dans le domaine
including
de
working
santé publique
in
au
the public
Kenya, y
and private
compris
sector, as
dans
well as
les
the
secteurs privés
NGO
et
sector.
publics et aussi dans le
Dr.
secteur
Canary
de
joined Amref Health Africa within Amref Enterprises Limited as the clinical lead. And before joining Amref Enterprises, she worked with PS Kenya as the
avant de
technical service delivery
travailler
lead. And here she has provided technical oversight
et
on various
ici,
programs.
elle a donné la surveillance technique.
And such programs cover the private sector,
Et de tels programmes couvrent le secteur privé,
research for development and communication for prevention strategies. And her current docket includes non-communicable diseases with a bias towards diabetes, hypertension, cancer, and mental health. And it also includes palliative care and aspects of integration of non-communicable diseases.
Ceci comprend aussi l'accès aux soins palliatifs pour des maladies non transmissibles
into universal healthcare coverage. So you're very welcome, Dr. Catherine.
Donc, vous êtes le bienvenu, Dr. Canary.
Dr. Catherine, you have 10 minutes.
Thank you so much, Dr. Eve.
Sorry, Dr. Catherine. Sorry, Dr. Catherine. I think there's somewhere that the lines have gotten mixed up because I can hear that the English-speaking delegates can hear me. So give me 1 minute. Give me just 1 minute.
We could hear you.
Okay. So now that I have you, please go to the interpretation section and click on the language you want to listen in, if it's English or French, and then also click on mute original audio. So you only hear one side. Is that okay?
Thank you.
Oh, sorry. And before we continue, the other interpreter has yet to be assigned. So I think he's still outside.
Okay, so we are ready.
So, sorry? Yes, I'm saying the other interpreter is yet to be.
Yes, Eve, we are getting you.
Okay, thank you so much for the introduction. As has been mentioned, my name is Dr. Catherine Canary, and I work for Amref, under which part of my docket involves integration of NCDs into government system, especially NCD supply chain, which pertains to this call as palliative care. So we look at, in general, how we get to the last mile. So how we impact the patients and how we advocate for these patients to get the much needed drugs, especially for palliative care and pain management. So some of the challenges that are within Africa in this sphere include, one of the biggest things is the cost of the drugs, because as of now, within Kenya, 1 kilogram of morphine powder probably gets here with around $4,000. That's a huge expense, and yet we have a population who needs it. So one of the key issues is cost, and one of the key solutions to that, I believe, is that we need to find a cost-effective way, whether it be full procurement or strategic purchasing, that we're able to now get these drugs at a good price and to the consumer. So within Africa as well, one of the key issues that is a sticking point for access to this medicine is myths and misconceptions, both for the providers and for the patients themselves. So it's been construed that by the time you need opioids for pain, you're at your last mile of life. And some providers also do not know how to communicate this, and they don't know how to treat patients who need this important medication. We have come a long way in Africa from the time of essentially integrating palliative care medicines into essential drug lists. And most countries have benefited from this. Some have not, and therein lies another challenge, that these drugs need to be put in the essential drug list so that the governments are able to procure them for the public that requires them. The other issue then becomes, once they're in the country, there's been challenges in control of them and controlling the stocks and controlling the quality of mixing. And generally, by the time it gets to the patient, sometimes we don't know the quality of what we are giving the patient and how it will alleviate. So one of the things, or one of the strategies that we have seen working for Kenya and other countries is centralizing this process specifically for opioids, where you have a centralized system of procurement. You receive the drug, you then have a central system of distributing them based on orders, and then you have a channel or a network of professionals who are then handling this drug. So therefore, it ensures that we have a forecasting system. It ensures that at the last mile where the patient is concerned, we have a qualified technical person who is able to walk the patient through and to give access for this medicine for them. The other thing would be that in as much as some countries have no access, there is a need for advocacy for the same. Increasingly, NCDs have become a problem. In Kenya, I know we lose so many patients per day from cancer, and majority of those patients will at some point require this pain medication. And so ensuring that they're able to do this, we'll need some innovations around even patient feedback, patient information, and also for systems within the community that are able to then give the feedback. So using maybe community health workers, using any healthcare worker who is found within the community, that they're able to now come in and get the feedback from the person who requires the medication. And so there's a feedback loop to the facility. I can see someone saying the audio is not so good, so I'm going to try and change my audio from the headphone to the computer. But I think I've covered majority of the salient points I wanted to talk about for access to this medication. I believe the last thing is to look at it as a long-term approach. If you're looking at it as a long-term approach, most African countries are trying to figure out universal health coverage. And so that discussion needs to include NCDs, and it needs to include pain management and palliative care as part of NCDs. And this will take advocacy from the clients, and it will also take advocacy to the government and to the national government. And even looking at a way, because currently we import majority of, for example, our morphine. We have no local or African source for some of the countries. And this is a challenge that can be circumnavigated if we pulled together and did a sort of full procurement per country, which would be able to help us negotiate even the pricing that we currently have for the same. Because at the end of the day, in some systems like our system, where there's devolution, the government or the county, not the country, has to then negotiate for prices for their clients. And so when it's fragmented, it then presents a challenge in pricing. If we're able to do a strategic purchase for this medicines, we'll then be able to have a better bargaining power, and we'll then be able to, in essence, at least get the right amount we need and the quantities that we need to get to our patients. So I think, I don't know if my 10 minutes are up, Dr. Eve. I might save up some for the questions and for the next presenter. But I believe those are the salient points that I wanted to put across when it comes to access to this medicine. Thank you.
Thank you very much, Catherine, for that excellent presentation. And I will encourage participants to keep writing their questions in the Q&A section. We'll have an opportunity to request the panelists to respond to all the questions. And our next speaker is Mr. Adelowu Adebei, who is a member of the West African Commission on Drugs, and he will be speaking about the drug control system and access to medicines, recommendations of the model drug law. And Mr. Adebei is a public health expert who has worked on a wide range of issues such as HIV/AIDS, sexual and reproductive health, drug response, and youth development. His leadership and work have gained several recognitions, such as the prestigious Red Ribbon Award by the UNAIDS and the African Union Compendium on Good Practice on Drug Use Prevention, Treatment, and Harm Reduction. He's the member of the West Africa Commission on Drugs, a regional initiative convened by the late Kofi Annan and chaired by the former president of Nigeria, Olusegun Obasanjo. He has facilitated the formation of the West Africa Drug Policy Network, a coalition of over 300 civil society organizations in West Africa who are promoting drug policy reform. So you're very welcome, Mr. Adebei. You have 10 minutes.
Okay. Thank you very much for this wonderful opportunity to join this conversation that is very important to us within the African continent. And as you rightly mentioned the topic, the drug control system and access to medicine, the recommendation of the model drug law. First, permit me to give you some background to the model drug law, which was launched in September 2018 by the West African Commission on Drugs. And this was necessitated by the fact that the current laws that we have in terms, for drug control response are not having the desired effects. So we embarked on a review of drug laws within the region in West Africa, and we found a huge variations between national drug laws within the region. And most of the laws are based on prohibition and the use of repression. And of course, in 2014, we released our flagship report, Not Just in Transit, the State of Drug and Society in West Africa, in which we call for a political, call on political leaders to change drug laws and policies. And this was followed on by a lot of advocacy visits. So there was a need that we saw for us to have a model drug law within the region. And we also see the strong linkage between drug laws, drug policy, and access to control medicines as well. So what is a model drug law? The model drug law provides model legislative provisions and commentary to support and harmonize national drug laws reform within the region. And this is actually based on measures required by the 3 UN drug control conventions. We reflected on the UNGA's outcome document, the ECOWAS document, and the African Union commitments. We also, look at effectiveness and known best practices that we can bring together and promote within the region. And for every recommendation that we made, we provide a rationale, for it. So you can look up the document online and to have a comprehensive look of what the provisions are within the document, as time will not permit me to speak about the entire document, but there are interesting provisions within it. Experts were involved, consultations were done, and now we have a document available. But now, in terms of the topic we are talking about today, and before looking at the specific recommendations of the model drug law on access to control medicine, it is important for us to note some factors that actually informed our recommendation. We noted that repressive and overly prohibitive drug policies has implications and contributes to the poor access to medicines in the continent. Also, the international conventions on drug control and how they have been interpreted by governments within the African settings are an important barrier to access to controlled medicines. And furthermore, we know that many controlled substances play a critical role in medical care for relief of pain or the use of anesthesia, surgery, treatment of mental disorders, and what have you. Unfortunately, the obligations to prevent abuse has actually received far more attention than the obligation to ensure availability of the medical care. I will give you an example. According to the 2018 report by Lancet on global access to pain relief, only 0.2% of everyone who needs pain medication has access to it in Nigeria. Therefore, a very huge unmet need, in the entire population. And this figure is also very similar in many other African countries where it is the same, when people who are actually in need of pain medication do not have access to it. But it's the opposite that we see in developed society. So there's need for us to have a review or a look at the issue. So if we are looking at few elements that has contributed to this crisis, which is obviously a complex problem, we will say that many countries have misinterpreted the convention. We need to know that an effective drug control regime that complies with the spirit of the International Drug Convention should actually strike a balance between ensuring the availability of controlled drugs for licit uses and preventing the diversion of controlled drugs to illicit uses. I know in recent years, the international policy discussion on drug has shifted much of its focus towards ensuring access to controlled substances for medical and scientific purposes, even just as we are having this conversation now on access to controlled medicines. But unfortunately, despite these conversations going on, most of the laws and policies related to controlled drugs in Africa has not changed. They only contain provisions on preventing the diversion for unauthorized use. Nothing much has actually changed. So we need to actually strike a balance as we continue this conversation. And another point that has actually contributed to this crisis is also economic issue. If you look at the healthcare budget, good enough, the first speaker mentioned the issue around costs. If you look at the healthcare budget in many African countries, the budgets are still very low. Some of us can remember the Abuja Declaration about 19 years ago, where African governments pledged at least 15% of their annual budget to improving healthcare. Unfortunately, that is rarely happening. It's not being implemented. Most health expenditure are still out of pocket. If you look at the WHO estimation, out-of-pocket expenditure represents about 90% of the population in low and middle income countries. So the poor who are in need of this pain medication might not be able to pay even when it is available. And another point, that is deepening the crisis is the complex and inefficient drug procurement system. If we look at the influence of commercial interest and what have you in the drug procurement system, we know this is a challenge. And another point I want to be quick to mention is the lack of information available to healthcare workers. And for some of them, the fear of prescribing the drugs due to diversion or the fear of arrest and other conditions. And in countries where there's even some level of availability, the geographical coverage is so poor. Access is limited to most of the time tertiary institutions, most of which are situated within the urban settings. So this begs the question on how do we manage pain or ensure access for many of those living within the rural settings who are in pains and actually in need of these substances. So geographical coverage is even poor, even where it is available. So, having said all this, we can see that drug policy in itself has a major role to play if we are talking about access to controlled medicine. The three international conventions, despite some flexibility, has been misinterpreted by countries in favor of repression and overly control of pain medicine. So there's so much fear around diversion than even ensuring that people who need it have access to it. And secondly, the international community actually need to recognize the incoherence and inconsistencies in the international scheduling system, how drugs are scheduled and the restrictions placed on them, how the incoherence and the inconsistency affect the availability of this drug. And we must be able to trigger a critical review of the current models of classification of drugs. There are a whole lot of negative consequences of the current international scheduling system, such as the scarcity, the non-availability, like the first speaker also even mentioned, you have to depend on, foreign companies to be able to, procure some of these drugs, some of these medicines to make them available within the continent. It is very difficult to see that because because of repression, there's scarcity in low and middle income countries. This leading to, high mortality, lack of access to pain medication. And this is also why they call for global, scheduling. If you look at the moment, there's been a kind of a clamor for global scheduling of tramadol, which we consider to be inappropriate, because this happened to be one of the cheapest pain medication that we even have access to within the African setting. And if that also goes into global, international scheduling, and it's going to be so inappropriate and we affect Africa more. I would like to refer the audience to some publications by the Global Commission on Drugs, which are actually available online. These are the Global Crisis of Avoidable Pain, which was released in 2015. You can check that up. And also a publication on the classification of psychoactive substances, which was released in 2019. This will give us a more comprehensive information about what I'm actually talking about. So we need to look at that comprehensively. So in bringing my presentation to a close, in order to increase access to controlled medicines, the model drug law actually provide clear exemptions for authorized medical use of otherwise prohibited substances. Substances used in drug treatment for those who are dependent on drugs like methadone should not be prohibited. Naloxone to reverse even opioid overdoses should not be prohibited. And it also recommend that there should be a allowance for greater use of controlled medicines for pain relief. We should not restrict it to like maybe a doctor's prescription, but at different levels, health workers can be trained to be able to provide and assess these services for their client. We should allow health professionals to perform their duties without fear of reprisal. And one of the critical recommendation also in the model drug law is the need for countries to constitute a commission. It could be a department, it could be a commission or an agency that will look at, or a technical group that will look at improving access to essential medicines that are actually controlled drugs. This should be overseen by the Ministry of Health. And the duty of the commission will be to prepare a national policy for access to medicines that are controlled drugs, and to include within this policy some of these, some critical objectives, like ensuring availability of controlled drugs that are medicines for use in healthcare delivery, ensure education of regulatory bodies and stakeholders not only within the health sector, but also including law enforcement on the need for improved availability of controlled drugs for medical and scientific purposes, and also, of course, in the use of pain management. They also need to, focus on improving the capacity, the knowledge, and the skill of healthcare workers, among many other responsibilities that they need to focus on. And, lastly, we need to pay attention to the fact that when we are talking about balancing the drug control legislations and policies, it is very wise to leave the medical decisions up to those who are knowledgeable on medical issues. Because as we have seen in many countries, as we are even talking about access to pain medication, those who are making the decisions or the critical decision makers on these issues are not necessarily, medical experts, but people with political influence or who are able to affect legislation. So as we are talking about balancing the drug control legislation, between ensuring that these pain medications, control medicines are available for medical and scientific uses, and also preventing diversion, it is very wise to leave the medical decisions up to those who are knowledgeable on medical issues and not decisions to be made by politicians. So thank you. I'll be available for more questions because of after this session, if there are need for further clarification. But the model drug law is available online, and we can actually look that up for us to see more about the provisions within the document. Thank you very much.
Thank you very much, Mr. Adelo Adebi. And I encourage participants to keep typing the questions in the Q&A panel. The panelists will have an opportunity to respond to all the questions. And our next presenter is Miss Edith Andrews Anna, and she's from the technical office of the WHO office, Harare, Zimbabwe, and she will be speaking about WHO's support to African countries on access to medicines, main challenges, and progress. You're very welcome, Edith, and you have 10 minutes.
Thank you very much. I have a presentation. I think I'll share my screen. Good afternoon, everybody. Oh, the host has disabled participant screen sharing. That's what I'm told.
I'll give him an opportunity to enable that. Okay. Francis, kindly enable screen sharing for Edith to share her presentation.
Done. Edith, please try now.
Okay, so can you see my presentation?
Yes, I can see your presentation, Edith.
Okay, thank you very much. So I'm making this presentation on behalf of Prof. Jean-Baptiste Nikema, who is the team lead for medicines, supply, health infrastructure, and equipment maintenance in the WHO African Regional Office. So my presentation outline is this. I'll give an update on access to medicines, the support WHO is giving to countries, the main challenges, and the way forward. So for countries, for the Sustainable Development Goals, countries, governments are required to ensure good health and well-being for their citizens. This is the goal 3. And the target 3.8 requires that we have to achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for everybody, for all. That is the requirement for us as governments and countries. In achieving access to medicines, there are quite a number of things that we have to do. We have to go through research and development. We go through the manufacturing process, marketing and registration, selection, pricing and reimbursement, procurement and supply. We have to do the procurement and supplying. We have to prescribe, where we have knowledgeable prescribers who can prescribe. We've been talking about prescription of pain medicines. People should be able to prescribe. We have to be able to dispense these medicines, and those who are supposed to use them should be able to know how to use these medicines. So in achieving access, all these things will come into play. For WHO, we have some policy measures for prioritizing the investment. 47 countries in our region have national medicines policies. We talked about medicine policies. 44 countries have national essential medicines list. 15 countries in the region have universal health coverage roadmaps. Then 65% of our countries have tax exemptions and waivers for pharmaceuticals. We've tried to improve the capacity for selection of essential medicines, antibiotics, and innovative products. You can see some of the policies there. We have that one for Kenya, we have for South Africa, and we have celebrated almost now is about 43 years of the model list of essential medicines worldwide. The mean availability of opioids for pain management, you can see in the African region, the map shows a lot of white areas and a lot of light blue areas. The light white areas is less than one daily divided dose per million for opioids for pain management. Most of us are in the white and in the light blue and a bit in the dark blue area. It means that we are not doing very well with use of opioids for managing pain on our continent. There was a survey that was done, and in the African region, less than 10% of the facilities have access to morphine injection. You can see with the bars, we have Afro countries, we have about 13 countries. Most of them, the blue bar is the morphine injection. Most of them had low availability. There was only one country that had 50%. Most of them had low availability if you compare to the other regions in the world. As part of the COVID-19 pandemic, we're looking at the supply chain, the disruptions that we are experiencing in the supply chain. Afro conducted a risk assessment of countries. We could see a lot of stockouts of medicines in countries. We could also see that the stockhouse also included a lot of the medicines that were out of stock were various medicines for palliative care. Pethidine injection and morphine were out of stock when this assessment was done. The bottlenecks that we found were that there was difficulties in negotiating tendering with the suppliers, risk of stockouts of medicines, price of the product had increased, delivery challenges, distribution to other facilities was a problem, and so there were a lot of stockouts. And this included medicines that were needed for pain management. Some of the barriers to access to controlled medicines include, this has been mentioned already, lack of awareness among policymakers, health professionals, and the public about palliative care and the benefits it can offer to patients and the health systems. There are also cultural and social barriers, and then beliefs about death and dying. There are misconceptions about palliative care. They think it's only for people who have cancer or for the few that are in the last week of their lives. There's misconceptions about improving access to controlled medicines, and it has been mentioned that people think that it will increase substance abuse, and then also it will be diverted, and this will require sanctions. At the service delivery points, we have limited prescription duration. If you have the prescription for controlled medicines, it's limited. You have to have special prescription forms. There's limitation of dispensing outlets, limitation of prescribing. It's only certain doctors or certain medical professionals who can prescribe pain medicines. And there's restrictions also on exports and imports. You need special licenses to be able to import these medicines. The challenges, we have limited infrastructure for diagnosis and treatment. We have inadequate financing to purchase the medicines. The procurement procedures are cumbersome. Lack of adequate data on efficacy, safety, and comparative cost effectiveness. There's also the social stigma that we've talked about. And then the perception that disease for which controlled medicines is needed is a fatal disease. So the African region has supported some of the countries to look at this and see what can be done. In the Democratic Republic of Congo, DRC, there was an assessment of availability and price of medicines for pain and palliative care, the assessment of the laws and regulations of medicines, including controlled medicines. There were interviews of key players to explore the barriers to prescribing, procurement, and dispensing of controlled medicines. And there was a national workshop on access to controlled medicines. There's analysis of the survey results and the planning of policies. What are the best practices? And this will all be implemented. There's also advocacy for addressing barriers to access and use. Ghana was another country that was supported also to do an assessment of availability and price for medicines for palliative care, prescribing, dispensing, and use of medicines in palliative care. For the findings, it was found that only cervical and breast cancer treatments were listed in the Ghana National Health Insurance Scheme Benefits Package as of June 2017. Devices to aid diagnosis and patient monitoring were non-functional at the time of the study in many of the facilities. For availability of the medicines used for the treatment of cancer, we only found in 31 out of the 67 facilities that were surveyed. Regional hospitals, regional medical stores, central medical stores, and district hospitals did not stock anti-cancer medicines. It was only found in tertiary hospitals, the teaching hospitals. Affordability of treatment. The treatment was quite expensive and not affordable using the daily wage of least paid government worker. Some patients relied on non-governmental organizations and benevolent organizations such as churches to pay for their treatments. And family members needed to contribute to support a patient, including siblings, stopping school so that the cost of the treatment can be catered for a child with cancer. So the discussions have been ongoing in the region over the past couple of years about the relevance of controlled substances for medicinal use. Some countries, Lesotho, South Africa, Zimbabwe, and Malawi have adopted laws allowing cannabis growth for medicinal use. Namibia and Eswatini are also looking to do the same. So what are the steps for improving access to controlled medicines? We need the policies, the essential medicines regulatory guidance. We need information and advocacy, the formulary, updated treatment guidelines. We need stakeholders to be involved, markets and supply, clinical trials, procurement, and the supply chain. We have to see how we can have them all working together. And then the medicines availability and price and use, you have to measure them and collect data. And then for the interventions, there's need for behavior change strategies to change the way we think about access to controlled medicines. So what is our call to action? Our call to action is to promote availability of generics, reduce prices, and improve affordability, include in national essential medicines list, and on national health insurance schemes. We said we have universal health coverage. How can we get everybody, not leaving anybody behind, to have access to controlled medicines if they need them? We should think about alternative financing mechanisms. We should have efficient procurement of quality assured products, effective distribution networks, as we saw in the COVID-19 experience. Distribution networks were not working well. We need to increase geographical access, the size, the staff capacity for diagnosis and treatment. And we need to also monitor. We need to do population-based surveillance. We monitor with comprehensive data. We need to involve our communities in this aspect of improving access to controlled medicines. Sometimes patients will wait till the end before they report to the hospital. How can we change this? They have to report early so that the diagnosis and treatment can be done. So in conclusion, I say that the need to improve access to controlled medicines is very obvious. The challenges are surmountable. We can do something about it. We need sustained commitment and partnership by all stakeholders. And then access to controlled medicine should be seen as a right, and every effort must be done to meet this right. Thank you very much.
Thank you very much, Edith. That was a comprehensive presentation from a pharmacist who is also a specialist in medicines regulation. So our next speaker is actually a patient, and this is Dr. Stephen Watiti, who is a medical doctor and a palliative care beneficiary. And Dr. Watiti's story is interesting. He thinks he got infected with HIV in 1986. That was early in his career as a doctor and soon after getting married. And in 2000, Dr. Watiti, and since 2000, Dr. Watiti has been on antiretroviral therapy after battling tuberculosis and cancer, that is Kaposi sarcoma, and also cryptococcal meningitis, 3 things at a go. And his quality of life has greatly improved since he started antiretroviral therapy. And he believes that HIV, though incurable, can be managed with the advent of antiretroviral therapy. Really, Dr. Watiti doesn't need a lot of introduction, and I beg not to preempt his interesting story. I'll straight away hand over the floor to you, Dr. Watiti. You're welcome, and you have 5 minutes.
Thank you very much, Eve, for that introduction. And thank you all my friends who have already presented, especially I hope they can share the slides so that we can continue. As you've been told, my name is Stephen Watiti, and I'm a patient, though I'm not sick really at the moment because I'm okay. But I guess I'm referred to it that because in 2000, I was a very sick guy. I was sick with TB, MDR TB, Kaposi sarcoma. And I was not on antiretroviral therapy, so I was really waiting for death.
Sorry to interrupt. Is everyone hearing Dr. Watiti?
Oh, we are not hearing him.
No.
No.
Sorry, Dr. Watiti, we are not hearing you.
Oh, what is the problem?
I can hear him.
So some people are hearing him, some are not.
I can hear him.
Oh.
Dr. Watiti, just say something again, let's hear.
How do I know? Hello, everybody. Can you hear
I
me
can't
now?
hear him at all.
No.
You can't hear me at all. I can hear you.
Frank, can you assist?
But I'm hearing all those who are saying they're not hearing me. I'm sorry.
So it's like half of us are hearing you and the other half are not.
Ah, is that my fault? You know, I'm not so good with what. So what do I do, Ezra? I go on?
Eve?
I can hear him okay.
Maybe we should proceed. Frank will.
Okay, let me go on assuming. Okay, Frank, do that magic as I continue.
Yeah. I'll try to turn off my camera. With Zara, you could also turn off. Probably that could help.
Thanks again, friends, me at the beginning, but I hope you are hearing me.
Yep.
Okay, please proceed.
Should I turn off my video? I am sorry, I don't know why this is happening when I'm talking, but all the same, I was saying my name, you've heard it, and I'm a recipient of In 1999, 2000, I had TB. I have had TB 5 times. That was the 5th time, and it was MDR TB. And then I developed Kaposi, and while I was still battling those two, I developed cryptococcal meningitis. That one caused a lot of headache, pain, which was so difficult for me to handle. At that time, I was lucky that I was referred for palliative care, and I'm saying I'm lucky because many doctors don't refer. They leave you to just battle pain. I was referred for palliative care, but I refused to go for it because in my mind, I knew this was like end of life, and I didn't want to think that I was dying. I thought doctors would do better. But I was lucky again that there was a palliative care nurse. This lady helped me a lot. She actually trained me on palliative care and put me on morphine, which helped reduce the pain. One of the things I feared most was the addiction to morphine. But again, she told me, well, that was a doctor I should have known, but I didn't know, that morphine, when used for medical purposes, you do not get addicted to it. And thank God that when the pain went, I have never had any craving for morphine. And I think in all the presentation, I've seen quite a word said about advocacy. When we think about advocacy, we need to think especially about people like me who have used or are using palliative care, including morphine for pain. And they are able to tell their stories. Sometimes it's quite intimidating and people don't want to talk about their personal experiences. But if there are those who are trained, I'm sure they can share their stories with good effects. We also need to especially train our doctors to be able to know when to refer these patients in a timely manner so that they can be put on palliative care. And being put on palliative care does not necessarily mean you're going to die. You can see that 20 years later, I'm quite alive and well. I care for my mom who is 90 and my mother-in-law who is 91, and I'm now thinking that I'm going to need palliative care as I age with HIV because I don't think I'm going to die of AIDS, but I'm going to grow old. But I can see that the needs for palliative care, my parents are not sick, really, but they're old and they need palliative care. So we need these palliative care advocates and to keep mentioning that it is not universal health care if palliative care is not provided as part of the continuum of care for people, for us living with HIV, but other people. We need to prevent, promote health, sure, if we can, and rehabilitate those who need rehabilitation, but surely we also need palliative care. As I finish, I think I need to mention that advocacy, especially with our governments, needs to be done, and people like me and others who are on palliative care ought to be at the forefront of this, because there needs to be funding. In my country now, there is morphine for some people who can access it, who are referred. But the truth is, if people start referring these patients, the need is going to increase and the morphine is going not to be enough. So we need money for morphine. We need money to train palliative care nurses. We need money to put their facilities for these people to be cared for. So we need to demystify palliative care. We need to debunk opiophobia, the fear of use of morphine. I have never had the craving for morphine since I stopped using it. And I know that people who fear it, especially if they use it for medical care, don't do it for a good reason. I thank you so much. I'm sorry for the glitches that you couldn't hear my first part, but I thank you all, and I thank you for the good work you're all doing.
Thank you very much, Dr. Stephen Watiti. Dr. Stephen Watiti is such a great writer, and he's a columnist in one of our leading newspapers in Uganda, The New Vision, and he has a great book on living positively with HIV. It never leaves my bedside. And our next presenter is also a patient, an adolescent who is 16 years old. And I'm pleased to introduce Godfrey Odongo to share his story as a patient. Godfrey, you're very welcome.
Thank you. Thank you.
Good. You're welcome to share your story.
Thank you. My name is Odongo Godfrey. I come from Soroti district. And before the sickness, I was in S2 when I was in 14 years. During my studies, I started experiencing body weakness, stomach pain, back pain, whereby I was referred to Soroti referral. That's in 2018. Reaching Soroti referral, there was no any other medicine that could help me. By then, still I was in too much pain. And the doctor started suspecting it to be cancer. And I was referred to Uganda Cancer Institute. Reaching to Uganda Cancer Institute, still I had a lot of pain, whereby I was diagnosed with leukemia, which is the cancer of the blood. And I went on further treatment. By then, still I had a lot of pain, and I was given morphine. Though there was no any other painkiller that could help me apart from morphine. I started taking my morphine, and later on in 1 week, I was taken to New Hope Children's Hostel, and I was still taking my morphine. From there, I did not have any other pain. Even the stomach, which was swollen, reduced. Even the pain reduced then and then. And then I encourage people to take morphine, especially children with cancer. Since I was taking my morphine in 2019, I don't feel any other pain again, and I don't take it anymore. Take only when I feel some pain. Thank you.
That is excellent. Thank you very much, Godfrey.
You're welcome.
Were you hearing anything?
Yes, I heard him loud and clear.
Okay.
Yes.
Okay, thank you very much, Godfrey. And if anyone has any questions for Godfrey, please jot them down in the question and answer panel. And our next speaker is Dr. Catherine Peters. Catherine Peters is the Advocacy Officer for the International Association of Hospice and Palliative Care. We all know Catherine as a great advocate for palliative care. She holds a PhD in political theory from Columbia University and a master's degree in health law and policy from the University of California, San Diego. She trained in California as a hospice volunteer in 2010, joining the Leadership Development Initiative at the Institute of Palliative Medicine in 2011, and then IHPC in 2014. And IHPC is International Association of Hospices and Palliative Care. You're very welcome, Dr. Catherine Peters.
Thank you so much, Eve, and it's a great honor to be here. Of course, I wish I could be with you in person, but we all know why. And really terrific presentations from everybody. I've learned so much. I just am going to make a very quick summary of what we do and why, because the answer to many of the challenges that the speakers presented is advocacy, which is really speaking up and speaking for patients and providers who need the medicines which are in such short supply. So I just want to introduce you to some of the resources that the International Association for Palliative Care has. We have a dedicated advocacy page. Our director, Dr. Liliana de Lima, and I published this article earlier this year on palliative care advocacy and why it matters. That's linked to on the webpage, as are many other resources I just want to show you very quickly, we have this page that has a link to our advocacy course, which is for our membership, which basically gives you a tour of all the international organizations where we work and how you can participate. It talks about our national and regional and global advocacy. It answers some very basic questions about what palliative care advocacy is, what our program is, and why we do it. Basically, we have a role in what's called global health governance, which means that we're a non-governmental organization, that's the official term, in consultative status with the United Nations Economic and Social Council. And we take a rights-based approach at the Commission on Narcotic Drugs, which is the UN organization relevant to this webinar, which governs and discusses access to controlled medicines as part of a whole spectrum of drug control, which some of the other speakers mentioned, which has been underemphasized for years and years and is now getting the attention it deserves from the International Narcotics Control Board, as well as from member states and the Commission on Narcotic Drugs. We're also a non-state actor, that's another official term, in official relations with the World Health Organization, which means we participate in global and regional meetings of the World Health Organization on invitation. And Dr. Watiti knows this because he participated in one of our side events in Geneva last year on palliative care at the World Health Assembly, when we were all allowed to travel, which was a really great side event, and he spoke about his experience there. So it basically gives us a forum to advocate at the global level. And then the other important thing about advocacy, and many of the speakers addressed this morning with evidence, is that you need evidence to advocate properly. And so the IHPC has a database on serious health-related suffering, which is the basis of our definition of palliative care. And you can go to that database on our website. That's totally free access. And there's step-by-step instructions about how to use it for each of your countries that allows you to do what one of the previous speakers talked about, which is to estimate serious health-related suffering, and then also get the distributed opioid morphine equivalent, which is the technical term for how much controlled medicines your country actually consumes and how much it actually needs. And if you need help with that, we have technical people standing by who can work with you on working this out for your particular country for evidence-based access. It's important to stress the ethos of palliative care advocacy and how we can become more powerful, because we can't just stay in our silo of palliative care. We have to do what's called intersectional advocacy, which means to create alliances with other human rights-based civil society organizations. And I know the folks in Uganda have done a really good job on this, and in Kenya. And in the various countries in West Africa that have worked with the Global Commission on Drug Policy, as well as with APCA. So basically, we want to work with drug policy organizations. That's how I got into the field in the beginning, with IDPC working on access to controlled medicines. We work with organizations of persons with disabilities, with refugees and migrants, prisoners, incarcerated persons, persons with homelessness, and LGBTQ community, and faith-based, very important, and secular humanists. So we need to make relationships and lots of new friends with different social organizations. We participate in these meetings that are coming up, for instance, one on October 21st, which will be a virtual meeting, of course, but all the countries in the world that participate in the Commission on Narcotic Drugs and discuss access to medicines, only on October 21st, they're going to be talking about medicines. It's what's called an intersessional meeting. It'll be live streamed, and if you follow us on Twitter, we can send you the link. I don't have the link at the moment. But the important thing is, and I can send you more information about this through the organizers, to contact all your governments with the information that was presented today by several of the speakers regarding availability of essential palliative care medicines in your country, so that their interventions are informed. In other words, all your governments are going to make a little speech at this meeting on October 21st about the state of access to medicines in your country. And in order for them to be informed, they need to hear from the palliative care organizations in their countries. Otherwise, they don't have the data. Nigeria is very important here, as is Ghana and Senegal, where they've done, and DRC, where they've done this assessment work with the help of what's called the Global Program at the UN Organization of Drugs and Crime. There's a particularly small funded program by Australia that helps countries do that. And there will be 5 civil society speakers at that meeting on October 21st. One of them may be from Nigeria. They haven't picked all the people yet, but the main panelist from civil society will be from Colombia. And she will be addressing how they're advocating for prices, what was addressed earlier in this webinar, as well as with other civil society organizations to improve access. So that's going to be a very important meeting, which I suggest you tune into. I know it's live streamed. I don't know if it'll be recorded. The other important meeting that's coming up on November 9th to 14th is the Extended World Health Assembly. And again, it's going to be key to contact your governments about their national statements at the World Health Assembly. And IHPC and the World Hospices and Palliative Care Alliance will be developing an advocacy strategy for that, which we'll communicate to all our members. Again, talking points for your governments that you can help them with. So thank you again for inviting me. It's a great honor to participate. And the takeaway for this, I would say, is that advocating for the right to access to essential palliative care members strengthens civil society, especially in countries where civil society isn't very strong. And it reframes the global health narrative away from just preventing mortality, which is the main thrust of global health, is to prevent mortality, not to provide care necessarily for people whose mortality can't be prevented, but they can certainly be cared for. And advocacy counter-institutionalizes harsh drug policies, which were referred to in this webinar, and which produce regulations and barriers which are difficult regarding access to controlled medicines. And it makes palliative care patients and providers visible to policymakers, because otherwise we're invisible to them because they haven't had to think about us. So that's why advocacy is so important. And of course, I'm standing by however you need me for more information. So thank you again, and thank you to the organizers for inviting me.
Thank you very much, our renowned advocate, Dr. Catherine Peters. So we are now opening up the floor for questions and answers. The first question is to you, Dr. Karani.
Kanari.
Oh, Dr. Kanari, yes. Apologies over that. May you please tell us if and how AMREF engages in terms of advocacy to remove barriers to access pain management medicines, and how policies influence access in the region?
Thank you so much. Thank you. I see it's Isabella who asked this question. So I'll give maybe a 4-point response to this. I hope everybody can hear me. First and foremost, I will say that AMREF CEO, Dr. Gidenji, currently sits in the UHC as a co-UHC, the World Co-UHC chair. He's a co-chair for that. And within that space, it allows for him to improve his advocacy for UHC. And this includes NCDs and palliative care. Secondly, AMREF as an organization has presence in 35 countries in Africa. And how we engage in these countries, once we do entry, it is always aligning to the government, and we align to the specific Ministry of Health and their priorities. So any intervention that we as AMREF take on, we first have to interact with the Ministry of Health and the policies, and then we go deeper into the community, because one of our biggest strengths is community health systems. And within that space, we do a lot, starting with training community health volunteers. We have trained at least 1,000 community health volunteers on palliative care. That I can speak for in Kenya alone. And within that space, they are going to the community, they are assisting patients, they are giving feedback. We train them in one of our platforms that is an innovative solution using M-Learning. So they use mobile phones, which do not even have to be smart. So we train them and capacity build them generally to have tenets of palliative care within them, and they're able to act as a go-between the patient and the healthcare provider. Secondly, we do collect data, again using a tool that we have on a mobile platform from the community health volunteers. And this tool is then able to actually feed back to the facility and give the community response or the patient or the client response, and they're able to have that seamless transition between facility and the specific patient who requires this help. The other thing we do as AMREF, we house something called Strategic Purchasing Resource Program, where we are able to act as a resource center. It's a funded sort of organization or sort of resource center, where we do talk and have dialogues and have other engagements with various governments who would be interested in doing strategic purchasing. So for example, if a government says that this is our priority, please assist us with the resources that we may need to carry out this. That is one of the key things that we do, having housed that specific resource center within AMREF. So those are just a few things that AMREF is doing in this space. The one and the last thing is the feedback from the patients and the impact sort of data that we collect, just to see if our programs and our projects are aligning. And this includes palliative care. As I said, we have some NCD projects that have cancer as one of the key NCD within them. And so this, we work together collaboratively with the Kenya Hospice and Palliative Care Association as well. And we are able to then map and integrate and also to link various palliative care providers within some platforms for discussion and forums, and to see how we can then push the agenda for advocacy within the various county governments and country governments. So thank you. I hope I've answered conclusively. Thank you.
Yep, thank you very much. And we have a comment from Professor Anne Merriman, and she says that while over 50% of cancer patients and many others are at home in poor circumstances in the community and they are suffering, injectable morphine is of no use. And her argument is that they need affordable oral morphine. Preferably, this should be provided free by governments. And she encourages people to visit the poor in their communities. Probably, Edith, you could comment on that. Edith? Hello?
Eve?
Yes,
Eve,
please.
I would just like to say that that's a fantastic suggestion. And before COVID, of course, one of the things that we included in our advocacy was suggesting that palliative care teams include media with permission, of course, of the patients, as well as any local politicians or national politicians or global reporters such as I know Hospice Africa Uganda took the Special Rapporteur for Health, Danius Puras, on a visit, that it's until people see the conditions in the homes and how palliative care helps them. They just don't get the message. It's very abstract. With COVID, of course, that's different. And I'm sure people are creative enough to include media and politicians in Zoom calls or other ways they're communicating with patients. But I think that policymakers need to have a firsthand experience of how amazing palliative care is. It's what I tried to convey in my book, and because that's just a collection of blogs of when I accompanied palliative care teams to see patients, and I would talk about what that's like and how important it is for the families, because that message has to get out. And Dr. Merriman and Hospice Africa Uganda have done a terrific job with that, but now with COVID, it's much more difficult. So thanks for letting me chip in there.
Okay. Thank you very much, Catherine. And we have another question from Antonia. And he says that oral liquid morphine is safe to use and safe for a patient to take home for self-medication as prescribed by the nurse, clinical officer, or doctor. And this is very evident based on the Ugandan experience. And the question is, how can this practice be scaled up in Africa?
Yes, thank you, Eve. I think I'll answer that. That
Yes.
best practice in Uganda can be scaled up. So what were the lessons learned? What was the method? Can it be written out? Can it be replicated? What were the challenges? How can oral morphine be included in national essential medicines lists? You have to include it in your national essential medicines list, and then it can be made available for patients. So the Ugandan experience has to be shared.
Yeah.
It has to be shared so that we learn from it. What were some of the best practices? How did it go? What were the challenges? So we do not replicate all those challenges. And then we can get it in other countries. So we need to share that experience. Thank you very much.
Thank you very much. And the next question is from John Vianney Amanya, and it's to you, Dr. Adibi. There is noted access to controlled drugs for non-medicine use, for example, trafficking and abuse by non-professional systems and individuals. And John Vianney says this is a policy issue, and he wishes to learn from you on how you're working to harmonize African region drug control policies to prevent or minimize harm and therefore pain, while making sure access is available for those who need these medicines.
Yeah, thank you very much for that question. Yes, there's been the challenge of diversion or the use of control medicines, for non-medical users. However, like I mentioned in my presentation, there's still for us to have a balance. We can't over-control these drugs and prevent those who need it legitimately or who require it for pain management not to have access to it. So we need to ensure that availability and accessibility is actually taken care of. Then in terms of diversion, one of the things that we have spoken for is the need for a public health oriented drug policy, within the region in West Africa as a whole. Because of course, when you take the model drug law, you can also, even though it was written, with focus on West Africa, but it can be applied to Africa as a whole. There's need to have a public health response to, to look at the fact that even people who are, in quote, abusing the drugs need to have access to not criminalization, but public health services to help them, in their drug use, albeit access to harm reduction services, even we are talking about prevention, evidence-based prevention services. So we need to have this balance. Then in terms of ensuring a control, we need to strengthen our drug distribution channels. Rather than looking at prohibition and looking at preventing access, the drug distribution channels actually is what need to be strengthened to ensure that we minimize diversion. And also we need to pay attention, instead of looking at those who are the users, we need to focus more on those who are the big fish that we call like the traffickers, who and we need to do that using targeted law enforcement rather than pushing everybody into the same, basket using, both the trafficker and the users, being criminalized together. So there need to be a balance. Those who need legitimate access to it need to have access to this, pain medication in terms of policy, and of course, updating the essential drug medicine list rather than total fear of diversion. Then also those who are misusing the drug, they need to have a public health response rather than criminalization.
Thank you very much. And the next question is from Mary Calloway. And I would like Dr. Catherine Peters to respond to this. If we can have some takeaway messages for the audience.
Thank you, Eve. I typed it in the, I typed a response in the box, but I'm not sure it came through. So the three I would recommend, just off the top of my head, one has already been mentioned, which is to make sure that essential palliative care medicines, which are already in the WHO model list, are included in your national essential medicine list. That's chapter 2 of the WHO essential medicines list. It's available online. And to also, the second one would be something I mentioned in my presentation, which is to build relationships with local media. It sounds like Dr. Watiti already is one of those people in Uganda, but build relationships with media and also with policymakers to showcase palliative care and the benefits that it provides to patients and families, not just patients, but how it increases the resilience of families and caregivers as well as patients. And 3, I think this one is very important because there's such a lack of evidence, is to ensure that the ministries of health, one, there's many ministries that are involved, but let's start with health, has a complete inventory of all the palliative care services in the country, many of which may be private and charitable and small, but that there's a complete inventory of providers and medical stocks for essential palliative care medicines. And then you make sure that they have the real inventory of serious health-related suffering, which you can get on our database, which I showed, so that they can start bridging that gap with the help of palliative care organizations through workforce training and improving access to controlled medicines. So the evidence and the tools are out there. It's just starting to pick them up and use them. And of course, we are at IHPC are standing by to help you however you need to be able to use those tools and do advocacy.
Thank you very much, Catherine. And we have a positive note from Professor Merriman that everyone is welcome to Uganda to see and learn from the Ugandan experience. And we have another comment from a colleague from Togo, Mr. Nabe. Palliative care remains absent in many of the African health policies of basic care packages, with almost half of African countries identifying no hospice. Is it true or not? Probably, Catherine, you could respond to that question.
Sorry, I'm not very, yeah, I am not terribly familiar with the situation in Africa. Just generally, it would be better if you, Eve, or someone from APCA answered that question, quite frankly. Or maybe one of the participants.
I would agree with the statement. I don't know why Mr. Nabe would disagree. Based on the work I've been involved in on this theme, I would agree with the statement.
Yes, for me also, I also agree with that statement. Like if you look at a kind of a recent report in 2019 actually showed that for West Africa, there are just around 52 palliative care centers, for such as hospices for about just 360 million people. That is grossly, inadequate, looking at the need within the region and looking at what is available. So we also want to agree with the statement.
And as we wait for more questions, there are two books to look out for. One is by Dr. Catherine Peters, and that is Global Palliative Care, Reports from Peripherals. And it's available via Amazon on Kindle and as well as paperback. And it has lots of chapters on Africa. And there is also a book by Dr. Stephen Watiti, Conquering HIV/AIDS, My Personal Experience of Living with HIV.
If my hand is up, but it seems you haven't seen it.
Okay, please ask your question.
But I wasn't asking a question. I was thinking especially that importance of us mainstreaming palliative care and making it important the way it is. They always stress disease prevention. They always we stress curative services. We need to make it clear that it cannot be universal health coverage unless palliative care is spoken in the same breath with prevention, health promotion, curative services, rehabilitative services for those who need them, and then palliative care. So we need to be able to talk to people where there is no need for palliative care. We talk about it, because when we mention it, when people are very sick, like they mentioned it for the first time when I was on my deathbed, people think of death, and it brings a bit of stigma, which is unfortunate. That's what I wanted to say.
Yes, thank you very much, Dr. Stephen Watiti. That is most appreciated. Okay, we have a question from Brandon Massa. And he says, in the panelists' experiences with advocacy at the level of national governments and international forums, what are some of the strategies that you have found to be effective for raising political priority for improving the access to controlled medicines?
Maybe I can say something on this, and I can start by saying that one of the things that we found successful was actually telling the stories of patients. And in this case, fortunately or unfortunately, maybe ensuring that the political agenda is presented by maybe showcasing or making politicians that are prominent or prominent people in government actually advocate for themselves, having gone through conditions that require palliative care. So that's usually a very strong message. And again, sharing impact stories from the community that are benefiting from this palliative care, whether by an NGO intervention or a government intervention, it has come in handy, just giving the human side of the story. So I think that's a very strong advocacy tool, and many more need to be explored and shared, as was shared here, because once you're able to relate with that human face, it then makes it a reality that needs to be then tackled, or a solution needs to be found to alleviate this situation. Thank you.
Eve, can I say something quickly there too?
Yes, please.
I totally agree with what Dr. Catherine just said about the voices of patients, but I would also add the voices of providers. We had Dr. Abadan Chansa from Zambia speak at the last Commission on Narcotic Drugs meeting. He had to do a short video, but he talked as a provider from Zambia about the difficulties of working with patients when there were stockouts of morphine. And he told particularly the story of treating his grandmother for breast cancer, and how because there wasn't enough morphine in the country, she had to basically hoard her medicines so she could sleep at night. So she didn't take morphine during the day, but she took it at night. So he shared this story with the Commission on Narcotic Drugs, and it's just this continual raising awareness of policymakers that it's this message that drugs, quote unquote, are so bad. The other very small key thing that we do is try not to use the word drugs. When we're talking about controlled medicines, we talk about medications, analgesics, opioid analgesics. We try to use more precise and non-stigmatizing terms. So that's another thought. It's providers as well as patients and families that are really the top line advocates.
Thank you very much, Catherine. And we have another comment from Professor Anne Merriman. Palliative care is looked on as a handmaid to other specialties because most African countries have not named it a specialty. And this hinders our work with oncologists and other specialists who think they know more without training than those who have been trained in its use. So how can we stress this with success to our governments? Any thoughts on how we can do the advocacy to overcome this barrier? Catherine, do you have a thought on that?
Yeah, I don't want to dominate the
Friends have been.
Oh, go ahead. Someone else should go ahead, and then I'll take it if you want.
Yes, I think that as you have said, we need to have advocacy from both providers and then for both patients. But then there's also the need for capacity building. We need to build the capacity of our healthcare providers in the area of palliative care. Most, especially in the lower level facilities, do not have that capacity. So if we want to extend availability to lower level facilities, we need to train the providers there. There's need to build capacity for treatments.
Okay,
and there was another, yes, most of the medicines policies around in the African region are old, most of them. So we need to look at how we can review the medicines policies and especially incorporate things on controlled medicines, palliative care in our medicines policies. We need to review them and then make them current, to look at current therapies, current treatments, what is going on, what is needed, what can we add, what can we remove. We need to review our national medicines policies, national essential medicines list, so we can have all these things incorporated. Thank you very much. Over.
Okay.
Eve, specifically to address Dr. Ann's question, one of the things that's important too is to integrate palliative care with primary health care, not just to keep maintaining it as a specialty, because there's now international norms which commit governments to integrating palliative care into primary health care under universal health coverage. All UN countries have agreed to that. And as I said earlier, I think WONCA, the World Association of Family Doctors, is now sensitized and is interested in specifically and explicitly including palliative care into their strategies. There's going to be a WONCA webinar soon on this, I think in about a month. I don't have the exact date. So I think it's important, and it's absolutely right that it's palliative care is an afterthought. It's not usually included, but I think including it in primary health care is a very important way to go, so it's integrated.
Okay. And then our colleague from Togo, Mr. Nabe, raises another important question. Funding for palliative care remains a big concern. Even where there is no interest, the lack of funding for palliative care remains a very big problem. How can we address that? Any panelist can give thoughts on that.
Permit me to just, make some comment on this. Like I mentioned in my presentation, it's if we are looking forward towards a change in this response, we need to look at the entire drug control policy regime within the African setting, because the suffering, the restrictions, and the lack of funding we are seeing today is actually entrenched within the repressive, drug response. So it's very easy to forget that there are people who are in need of care. There are people who are usually in pain, who need access to these controlled medicines. The fear of diversion, the fear of abuse has actually overcome, the heart of people. So oftentimes we even see this conversation being discussed more among the law enforcement, setting, rather than even within the medical setting where it should actually, sit in. So this is one of the, if we are talking about access to funding, then we need to really embrace the public health response that the entire even drug control response need to focus on. If we embrace that, and then we begin to talk about it within that confines. Of course, we've mentioned the need for patient community to be, voices to be heard more, medical personnel to also be mobilized, but let this actually, at the policy level, in terms of even structuring, we need to mobilize individuals and let us begin to look at this issue from the public health response and not overly controlling, the medicines because of diversion. So with that, we can begin to open up the space for even funding accessibility. So we need to look at some of the root causes, also looking at it from the top to address this issue appropriately.
Okay.
Yes, can I add on? I think that
yes, please.
The fear of abuse is real. When we are talking about fear of abuse and sanctions, it's real. We also need to balance those policies, the regulations on that. Otherwise, it will get out of hand. We need to balance them in our policies. We need to balance access. We need to balance abuse, use, and all that in our policies. So there should be a balance. The regulations should work. Otherwise, we are throwing caution to the wind. Thank you very much.
Dr. Stephen Watiti, is your hand up?
Yes, my hand is up, but I wanted to just add on the important, sometimes, of course, the fear of abuse paralyzes us. Many things can be abused. For example, we have seen guns are abused in Africa, but people continue importing these guns. That's not a very good example, I must say, but what I think we need to do is to highlight the cases where they were used well. Concerning funding, I think we need to do more, especially with because many of the treatment for people with the terminal illnesses are futile. And we need to look at, maybe as colleagues, I'm talking as a physician also, but we need to talk about this among ourselves. Do we need to refer this patient for this very expensive treatment, or some of this money could be channeled in palliative care? And many of them, when they are given palliative care, they may end up not necessarily dying, but their quality of life improves and they can be treated or at least live without having to live in much pain. That's what I wanted to say.
Thank you very much, Dr. Watiti. I'm looking out for any further questions or hands raised.
Eve, I can briefly answer that question about funding. The other tool that's available if you're working with your governments on some funding for palliative care is that the Lancet Commission on Pain and Palliative Care developed what's called the Essential Package, of therapeutics and medications for palliative care, and they've scaled it for countries of all income levels. And it's a very small percentage of the revenue, I mean, the budget of a country. And we have that tool again available on our website. I'm happy to share it with the organizers of this webinar, because it shows that for a fraction of, again, the drug policy control budget, these things can be made available, including human resource training and essential medications. So the tool's developed, it's just that you need to take it to your Ministry of Finance and show them that it's doable. The other thing that's important to address is corruption. There's a huge drain on health budgets because of corruption in some countries. There's going to be a special session of the United Nations Commission on Crime and I've forgotten the exact title soon, and it's a UNGAS on specifically corruption. So they'll also be addressing the drain of corruption on health policy, because there's plenty of money. It's not a question of money, it's a question of developing the budgets.
Thank you very much, Catherine.
Dr.
Catherine, your hand is up.
Yes.
Dr. Catherine?
Yes, thank you. So one of the things I mentioned at the beginning was that capacity building, but also when we think about funding, we can also start thinking about non-conventional forms of funding, and also rallying the farmer, really the producers of this product and of this important medication, and looking around at access programs that can allow people to get this drug, especially those who cannot afford, and especially for the poor and underserved communities. So one of the key things is thinking around sources of funding or grants that are able to then have a long-term implication. If you're able to rally a group of farmers, for example, to be able to then have an access program for this life-saving or health alleviating drugs, it would be good.
Thank you very much, Dr. Catherine. Dr. Catherine, your hand is still up. Is that a new one or the previous one?
I think it's the old one.
Okay. So we have another comment from Professor Merriman. Oromorphine has been used in Uganda for 28 years without diversion or addiction. And she says that pain is a psychological barrier against abuse. And she emphasizes that prescribers must be available to address any confusion in beliefs. And we have a couple of other references shared. There is one on UNGASS, and it's about the corruption. Unless we have other questions or comments, I'll beg to move on to thank all the partners. Do we have any other questions or comments? So I beg to profoundly thank all the panelists and the partners, most especially the Global Commission on Drug Policy. We thank AMREF, and then the West Africa Commission on Drugs. And we also thank Kawempe Home Care. And we thank you, Dr. Watiti, Dr. Catherine, Dr. Adibey, Dr. Catherine. We also thank you. We thank everyone for attending this webinar. Thank you very much, Edith Andrews Annan, for accepting to come and share your expertise on this theme. Wetzerai, do you have any final comments?
Thank you, Eve, and thank you to all our panelists and participants. I did mention at the beginning that Dr. Emmanuel is unable to attend. He sends his apologies, but he would have loved to be here. Thank you very much.
Thanks to the good work.
Thank you. And there was a request to share presentations. We'll reach out to the speakers and we'll share the presentations via email.
Thank you. Thank you.
Thank you very much, Eve. I really appreciate your work moderating the panel. It was great.